Good evening to all to this weekly huddle. My name is Anup Agrawal. I am an interventional cardiologist at Care Hospital, Hyderabad. I am joined by my colleague and co-host for the huddle, Dr. Praneeth Palamuri. He is also an interventional cardiologist at Care Hospitals. The huddle is an audience level interactive session where we discuss a variety of things, mostly focused around healthcare. The idea is to pick up a topic or a clinical case and try to restrict our discussion around that, something that we would have on our hallway or in our consultation room. The basic premise of the huddle is to bring those casual discussions to a more organized platform like this one and share our ideas. While we do want to talk about science, the huddle aims to bring out your practice patterns and understand the rationale, what makes you take a particular decision. The huddle is hosted every week on Wednesdays at 7:30 p.m. like the one today. And this is our 26th session in a series. On today's session, we will be talking and discussing around orthostatic hypotension and what are the management challenges, which I'm pretty sure all of us have encountered at some point in our discussion. To enable the discussion, I have requested a few guests for the session. I have asked my colleagues from internal medicine, critical care, and neurology to join me, and endocrinology, and hopefully we will see a few of our colleagues share their thought as well. I also welcome Dr. Rukmini. Dr. Rukmini is a neurologist who has very gladly given her time to discuss about this. I believe she works at NIMS. Dr. Rukmini, I welcome you for the huddle.
Thank you for inviting me.
Thank you, ma'am.
It's a pleasure.
Thank you, ma'am. I typically start the session with a clinical case we direct towards my co-host Praneeth. And then once we get his opinion about how he goes about it, the session will be open for anybody else to share their thought. And again, the idea is try to understand what we do and what is our thought process behind it. And in a way, we learn from your thought process. So Praneeth, this is the clinical case for you. And this is a patient I saw last month. The details may not be exactly accurate, but the premise is the same. So he is a 76-year-old male. He had a history of anterior wall myocardial infarction, and he underwent a coronary artery bypass surgery around 6 years ago. At the time, he was 70 years of age. Since he had an evolved anterior wall MI at that time, his ejection fraction at that time was about 40%. And since then, it had been more or less stable. He has not had any recurrence since then. He otherwise minds his own life, and he's doing okay. His other comorbidities include hypertension, dyslipidemia, diabetes for about 12-13 years, and he has some early vascular dementia, not necessarily interfering with his lifestyle, but easy forgetfulness. He also has got benign prostate hypertrophy. He lives with his wife, and these are the only two people who live in an independent home. Their kids live outstation. So that's the only two people at home. So he comes to me for a routine checkup. He is class 2 for his heart failure symptoms. He's not complaining about it. He does not have angina, and overall he's doing fine. His only complaint is that when he stands up from lying down position, particularly in the morning, he feels dizzy or he feels giddy for a few minutes. And after that, he is able to go ahead with his daily business. The symptoms are very much reproducible. It happens every single time when he gets up, but the symptoms are most marked early in the morning when he gets it. He otherwise is feeling fine. He never had a fall, but he says he got close to where he thought he's going to fall, but he was able to catch up something or whatnot. Otherwise, he's able to do his daily activities and he otherwise feels fine. He did check his blood pressure at home, and most of the time he checks it sitting position, and they revolve around 130 systolic, 120 to 130 systolic, and diastolic around 70s. I will also list his medications to you, Praneeth. He is on rosuvastatin and ecosprin. I will tell you the doses if you ask me. He is on carvedilol 25 milligrams daily dose, telmisartan 40 milligrams daily dose. He takes tamsulosin 0.4 milligrams at night for his prostate. He is on torsemide or Ditor 5 milligrams twice a day and aldactone 25 milligrams twice a day. All of these had been stable dosing for him for the past at least 6 to 8 months. For diabetes, he takes metformin and dapagliflozin. Dapagliflozin was started about 6 months ago, and he had been doing fine. Metformin is his old medication. So I suspected that he probably is having orthostatic hypotension. I asked him whether he has any uh, dehydration related conditions like nausea, vomiting, diarrhea, those kind of things, which he was not. He was eating okay. And even on my examination, he was pretty much euvolemic. I did put him in a separate room where I made him lie down for about 10 minutes. And after that, I checked his blood pressure. And his blood pressure lying down, systolic was about 170 and diastolic 92 with a heart rate of around 70s. Then I made him stand up. And after a minute of standing, I rechecked his blood pressure. And his systolic blood pressure fell down from 170 to 104. And diastolic pressure fell down from about 92 to more like about 64, 65-ish. And his heart rate jumped up to high 80s from low 70s. He did complain of giddiness at the time when he stood up. So I made him sit down again, and he did fine. I also checked his electrolytes, and they were all okay. So now this is the patient in front of me. He's 76. He otherwise is doing his lifestyle activity. He's on medications for his heart failure, coronary artery disease, prostate, diabetes, hypertension, and whatnot. But now he has got lifestyle limiting orthostatic symptoms, which has been documented on my examination as well. So Praneeth, if I have to ask you, how would you go about this case? And then we will revolve around our audience in terms of what they would also suggest. So Praneeth, for you.
Yeah. So good evening, everyone. So firstly, I would like to know what are his onset of symptoms, how long he had these things, symptoms, and how long was he using the previous medications that he had, and any recent onset symptoms, and trying to correlate it with any recent addition of new medicines or any change of lifestyle, trying to correlate with the symptoms and any recent change. Anything that you can help me out with that?
Yeah, Praneeth. So truly speaking, these medicines he has been taking for quite some time. The doses has not been changed recently. In fact, he says that he was having these symptoms for a long period of time. He cannot recollect when the first time he noticed. It is probably months. It is just that recently, in the last maybe 2, 3 months, he is noticing it more frequently. And if it wasn't for a routine visit, he may not even have brought it to you. But now, since he came for a routine visit, he is mentioning this to you.
Yeah. So the symptoms, what you said, classic of an orthostatic hypotension. So there are many drugs which can reduce his blood pressure or can predispose him to have this postural hypertension. Most there is a combination of a lot of drugs which I can, but equally these drugs are something which are important from his cardiology point of view or mortality reduction, whatever we talk about. Best thing which I would do, provided he was compliant with medicines and presuming that these were not the immediate precipitating cause, I would say some modifications, because his symptoms are predominantly only in the morning and rest of the day he's fine. I ask him to avoid swift change in postures. Ask him to get up slowly from the bed. Maybe first hang his legs from the edge of the bed, then try to get up slowly after maybe 2 to 5 minutes if possible, and then take his time slowly and then walk around. Avoid swift change of posture and see how is he doing. And if he's comfortable, we probably continue those medicines. But if he's still symptomatic, affecting his day-to-day activities, then I try to cut down some of the medications or reduce it. Because I would, at his age, I would look more at avoiding a fall and other issues rather than looking at the long-term things. It's like that risk-benefit ratio that you need to calculate. And for his age at 76, I'm more fearful of having a fall and fracture and morbidity than long-term outcomes. That's my take on this.
So Praneeth, a few follow-up questions, and then we will open it to the discussion. So The reason why I also think that we need to be a bit aggressive is because he says there are at times at home where he had to break his fall because he was pretty much close to. So that certainly is something concerning. What is the highest blood pressure, supine blood pressure that you would accept in these kind of patients?
What is the highest blood pressure that I can accept? Maybe 160,
Supine.
170 I will accept. If it is touching 180 or more, 170 or more, I would equally be uncomfortable in leaving the patient at that high pressure and will be tempted to add some antihypertensive. But I would have hypertension than having hypotension at this particular age group and in this patient.
Do you see any role of doing ambulatory blood pressure recording for these kind of patients?
I would probably do it when I want to challenge him with medication, or when I reintroduce a medication. Then probably with that I would do an ambulatory blood pressure, because at this point I think the diagnosis is already made, so I don't find any indication at this point of time.
And do you try behavioral therapy first, or you directly tinker with his pharmacologic therapy because of the concern of fall?
I would stress more on behavior therapy. I want to change his habits, because I want him to continue these things irrespective of the medicine. So first behavioral therapy, and then change the treatment. Again, presuming because he was already using these things for quite some time, and it's only the symptoms are only there at only in the morning time, and rest of the day is comfortable. I would change, or I would try to look into that aspect of his 24 hours, and if he can deal with it, probably he should be okay. So behavioral therapy first.
Perfect. Thank you, Praneeth. And I think with this, we will start our discussion. And if anybody has got any thoughts, please unmute yourself or raise your hand, and I will unmute you. And while you gather your thought, let me ask some of the audience members what their thought process of orthostatic hypotension as a general is, and what they would particularly do for this patient. And since we have Dr. Somaraju in the audience, he doesn't need any introduction. Dr. Somaraju, sir, if I could unmute you, and if you could just share your thoughts for this particular discussion that we are having about how you would proceed. Dr. Somaraju.
Can you hear me, Anup?
Yes, sir, we can hear you now. Yes, sir, please go ahead.
Thank you very much. Interesting and very common problem. The first thing I would think about is the most important drug that is producing the postural hypertension for him is tamsulosin. And also a combination of tamsulosin, telmisartan, and diuretic are, as a rule, at this age, they do produce initial hypotension, later they stabilize. Some degree of autonomic neuropathy is also likely, but we leave it there. But actually, the common story is that we have an elderly person, and we treat their blood pressures, and we give them ACE inhibitors and antihypertensive medications, and we send them to neurologists, and neurologists adds drugs related to alpha blockers, as we saw, and suddenly they went home and fell down, and they had a fracture, and that's the end of the story. And this is a very common problem. First, tamsulosin. Instead of tamsulosin, some alternative drug you have to look at. Second thing I would like to know is whether he needs that much diuretic. Twice a day he was getting what is LA size? What is the need for a diuretic for him? And whether diuretic can be reduced or can be stopped. And these are the things I will look at. And I will not go for, say, alteration in his lifestyle and all that. First, you have to correct the postural hypotension. And that requires alteration in pharmacotherapy we are giving him, and that's important. And also, by chance, if he is advised too much of salt restriction, that has to be taken care of us. Thank you.
Perfect. Thank you so much, sir. And in fact, I wanted somebody to bring up the diuretic therapy as well. This is what I ended up doing. I ended up challenging him with no diuretic therapy and see how he does, because it is easy to reinstitute back. if he goes into heart failure. But that was my approach, and I'm just asking other people about what their thought process is. Certainly, tamsulosin is a red herring, although we do learn that it is a alpha-1 super selective, where it only affects the peripheries, not the central. But we have seen enough of orthostatic hypotension with that. You did bring up neurologists, so I'm going to have our neurologist guest to give us their thought. Dr. Rukmini, there are times when these patients, they land up directly to a neurologist clinic. And what is your take on these patients, and how do you adjust it? Because they do have a certain degree of autonomic dysfunction, and they're not primary neurology conditions. They're secondarily related. So how would you take on this, Dr. Rukmini?
Yeah, so we do get that is true that we do get patients with, complaints of giddiness. They don't really see, that's another thing. So a lot of people cannot differentiate between vertigo and syncope or a pre-syncope. So this, they land up in neurology OP with the classical complaints of dizziness on getting up. So any patient who says that they are dizzy on getting up, we usually have to look for a postural drop. And so for me, if you ask me, I would probably not touch the diuretic, because I'd probably ask my cardiology colleague to decide whether the diuretics and the antihypertensives are required or not. For me, the easiest thing would be to actually stop the tamsulosin. So I'd probably tell them that stop the tamsulosin, see it, and if there's a change, you can take a call on it. So that would be my take initially. The combination of supine hypertension and orthostatic hypotension is always it's a difficult process to treat. So my other advice would be to asking them to, because we commonly deal with mild autonomic neuropathy, especially if the patient is on a long-standing diabetic. So we expect that there would be some amount of autonomic neuropathy. So I would also ask them to make sure that they have a head up position in the bed during the night. This works quite a bit for most patients. With behavioral modification, other behavior modifications has been told, like to sit up and go slow and come back. So yes, as a movement disorder specialist, treatment options are much more difficult, I think, with those conditions.
Perfect. Thank you so much, ma'am. I will get back to you with some of the neurology specific questions that I have. I'm inviting anybody else's thought about how they would go about it, or if they have any particular questions regarding this. Since we have a lot of senior guys in the audience, I'm just going to ask a few of them. Dr. Raghu, I'm sure you have seen so many orthostatic hypotension cases in your life. Dr. Raghu also is one of the cardiologists, needs no introduction. He is at CARE. Dr. Raghu, I'm unmuting you. If you could share your thoughts about how do you manage these kind of patients?
Yeah,
Dr. Raghu, yeah, please.
Hi, good evening to all. Good evening, sir. Nice to hear your voice again. Dr. Somraju pointed out some of the major causes when we are dealing with a cardiac patient who has orthostatic hypotension. Many of them, most of the patients are in the elderly age group. They're more than 65, 70 years old. And one must always keep in mind that neurological drugs like anti-Parkinson's drugs are very, very notorious in producing orthostatic hypotension. Alpha receptor blockers like prazosin is another culprit which produces, at least till they develop tolerance, they can be really responsible for a lot of orthostatic hypotension. Another thing, the cause for the orthostatic hypotension is one thing, treating it is another major problem. I have not really encountered a patient who's so bad that he requires mineralocorticoids, and I have no experience with the newer drugs. So quite a few pharmaceutical companies have come out with their versions of midodrine, which they say is very effective, but I've never had an opportunity to test. Most of the time in my elderly patients, I try to find out whether they have any varicosities, whether there could be a possibility of blood pooling in their legs, which may be responsible for the orthostatic hypotension. And if they're not case of refractory hypertension or they are not in class 3 congestive heart failure, encourage them to have a little more salt than usual, and also suggest that they wear stockings or tie their legs with firm crepe bandages, which will facilitate the return of blood to the heart and thereby possibly prevent some of the episodes of orthostatic hypotension. That's about all, Anup. I really have nothing much more to add.
Raghu sir, I just want to ask you one question, because most of our patients have primary cardiac problem. Let's say if we do have these kind of patients whom you are treating heart failure, which drug you prefer more, beta blocker or RAS inhibitors? When you talk about, let's say if these guys have orthostatic hypotension, you want to get rid of one of the two. In your opinion, which one we should go ahead with, like this patient with a EF of 40%, if we have to go that route?
I would prefer not to withhold their beta blockers. The current advent of the newer drugs like ARNI and the SGLT2 receptor antagonists, we have a better choice so that we can probably take off diuretics if they are not in class 3 or class 4, and then manage their heart failure with these drugs. Lately, there have been quite a few trials which have come out showing mortality benefits from both these drugs. And many of these trials of patients in class 2 do not have a diuretic. So if you, the first drug that I would take off in a person who has significant and distressing orthostatic hypotension would be a diuretic. I would persist with the other drugs, especially beta blockers, which may have, in some cases of autonomic disturbances, it might actually be beneficial.
Thank you so much, sir. Let me ask Dr. Guru Prasad sir's opinion. Dr. Guru is our internal medicine consultant at Care Hospital. And I'm sure, Guru sir, you see a lot of these patients with or without primary cardiac problems. And how do you typically handle these kind of situations? And do you offer pharmacotherapy in these patients? Guru Prasad sir, if you could unmute yourself first. For some reason, I'm not able to unmute people today. Dr. Guru Prasad, you'll have to unmute yourself first. Yeah, for some reason, I'm not able to unmute people today. It says request. Okay, we'll get to Dr. Guru Prasad. Anybody else who has got any thoughts on this question, on this discussion that we are having? Dr. Sai Vittal, if you could give your thoughts about how you manage your patients. I'm sure you have had multiple such encounters. Dr. Sai Vittal.
Good evening, sir.
Yeah.
First, I would optimize hypertensive therapy. I may not go like with a blood pressure of 170. I may be satisfied with a systolic blood pressure of 150 or so. And I will, you have given already one advice. Why not follow the ambulatory BP monitoring? It was very meaningful. Actually, we can see whether the BP is variable mornings or night, morning or a diet that we can see and adjust the blood pressure dosage. As Dr. Raghu has already told that the beta blockers are preferred. Diuretics, the minimal dosage only of diuretics, I will try to give. And then I will see for the other comorbidities like diabetes mellitus, which is one of the important conditions that can predispose to this. And I want to avoid as many as vasodilators as possible. That way, I think I will proceed in this case.
Perfect. Thank you so much, sir. One of the questions which has been asked is the what is the significance of diastolic hypotension? And truly speaking, I have no idea about it. And if anybody in the audience knows anything about diastolic hypotension, while there are criteria for diastolic hypotension and systolic hypotension, all of us, we address the systolic hypotension, not particularly the diastolic hypotension. I have never actively looked into it, and I personally cannot give any insight on it. So if anybody has any other thoughts, they are please unmute yourself and share your thoughts. In the meantime, let me ask.
Anu,
Yes, sir.
I can just say a few things about diastolic hypotension. But the spelling was wrong. And see, it's important to know a few things about diastolic hypotension. Number one, people after 55, 60, the systolic pressure start going up and diastolic pressure start going down. And the reason why diastolic hypotension is not often recognized is that from medical student days to now, we have a habit of stopping to listen to cortical sounds at 80 and don't go down to record the diastolic pressures to less than 80. That is the reason why it is missed. And then the significance of it, particularly in patients like this, elderly people, established coronary artery disease, established cerebrovascular disease, that perfusion pressure to vital circulations can reduce, and it is documented in some of these, at least two of the studies I know, that it increases mortality in elderly people with vascular disease, not only coronaries but other circulations. So diastolic hypotension is very important to keep it in mind. Less than 70 is unacceptable generally in these patients. And as Dr. Rukmini already pointed out, supine hypertension, one of the very important things that can be done is the elevation of the head and the neck. So please keep in mind diastolic hypotension is missed because we stop listening to heart sounds below 80.
Thank you so much, sir. That was quite insightful. And really, I admitted that we really don't pay that much attention. Today is the last day I was not paying attention. From here on, we would be. Guru sir, if you were able to unmute yourself, could you just share your thoughts about this and about any pharmacotherapy that you do in these patients?
Anup, actually, sorry, I missed most of the discussion because of some phone calls I was getting. But one thing I would do actually is we had a similar patient who was diagnosed as vertigo, and similarly, the patient had CAD and other comorbids, and the patient had this kind of giddiness, and he came with a vertiginous sensation. Ultimately, we figured out that he underwent an MRI, a Doppler, and everything. Ultimately, figured out it is probably pre-syncope which he was having, and we stopped the tamsulosin. So the patient definitely became better because his urinary symptoms were not much, and we did a ultrasound abdomen with post-void residue. The prostate was not a big issue for him, so we stopped the tamsulosin. One thing actually I would like to point out in these patients is that to rule out anemia, it's very important to rule out anemia because anemia remains a very important cause of orthostatic hypotension. So I would check the hemoglobin of these patients and see if there's no anemia. Also, between neurogenic and non-neurogenic OH, it's very important to differentiate both of them because the pharmacotherapy might change in either of them. And neurogenic orthostatic hypotension has got a higher mortality rate as compared to non-neurogenic. I'm sure everybody agrees on that. So if the increase in heart rate with drop in blood pressure is very important to differentiate between a neurogenic and non-neurogenic orthostatic hypotension. So I think in this patient, stopping of alpha blocker would be the primary thing which I would do.
Perfect. Thank you so much, sir. And anybody has anything to share?
Can I add a word on the diastolic blood pressure? No?
Yes, Raghu sir, please go ahead.
Yeah, so basically, as we get older, the elastance comes down, the aorta becomes stiffer, and the diastolic blood pressure tends to drop. One of the most important aspects of low diastolic blood pressure is that it can worsen angina in patients who have critical coronary artery disease, especially unlike the other organs, the cardiac perfusion occurs mainly in diastole. And if the LV end diastolic pressure is already elevated because of heart failure, then the critical factor for this angina could be a low diastolic blood pressure. Having said that, I really don't know how to manage these patients who I see occasionally because nobody has a clue to what kind of therapy would push up the diastolic blood pressure in these elderly patients. So it's an important aspect to remember that the driving force for the coronary perfusion is the gradient between the diastolic blood pressure and the LVEDP. And if the latter is elevated and the former is decreased, then the driving force becomes less and perfusion can suffer.
Perfect. Thank you so much, sir. And I think this is a very important topic because, or the concept, I should say, the so-called coronary perfusion pressure. Just like we talk about cerebral perfusion pressure, where you have a diastolic pressure as well as LVEDP. In those patients, they can have angina. So certainly, patients who have angina and who have got low diastolic pressure, that's very difficult entity, and that certainly should be addressed to. Let me invite some other thought process to see. We have endocrinologist Dr. Vrinda. Dr. Vrinda, I'm going to unmute you. If you could just, in fact, I cannot unmute you. You have to unmute yourself. I'm sorry. If you could just share your thoughts in terms of orthostatic hypotension from an endocrinology standpoint, any role of checking their mineralocorticoid levels in the body, or any role of giving drugs like fluorocortisone or anything in these kind of patients? Dr. Vrinda, if you could unmute yourself. Okay.
Hi, everyone. So for orthostatic hypertension from like an endocrine standpoint, I typically unless and until patient has certified like or diagnosed adrenal insufficiency, I usually do not recommend the use of fludrocortisone in these patients. Of course, I do want to check for adrenal insufficiency in any of these patients presenting to the clinic. So if that is ruled out, then I do not typically promote the use of fludrocortisone. As somebody otherwise mentioned, sometimes it is advocated, like midodrine use has been advocated in patients with orthostatic hypertension, but from endo standpoint, adrenal insufficiency, if it's there, we treat it, but otherwise don't use Florinef or fludrocortisone.
Perfect. Thank you so much. And I'll continue with the discussion. And again, if anybody has got any thoughts that they want to add, you can please raise your hand or you can unmute yourself. Let me go back to Dr. Rukmini. Dr. Rukmini, I have got few particular questions for you. Number one, Dr. Guru Prasad mentioned about neurogenic versus non-neurogenic orthostatic hypotension. All we know is orthostatic hypotension. We have no idea what is neurogenic orthostatic hypotension. If you could share your thoughts about it. Secondly, can orthostatic hypotension by itself be a symptom of stroke or TIA? The follow-up question is, can orthostatic hypotension be one of the early symptoms of some of the primary neurologic issues like Parkinson's or whatnot? And lastly, what is your thought process on the drugs like the metodrine, which Dr. Vrinda mentioned? And there are few other drugs which are mostly prescribed by neurologists. We have never prescribed those. If any of those medications, if you could highlight what are being used and what is your thought process on it. So a lot of questions. Dr. Rukmini, you can take a few minutes to answer this.
Thank you. So the question is, first is neurogenic orthostatic hypertension. Basically, the concept is that obviously your autonomic nervous system is at fault. So the autonomic nervous system, that is, I mean, you're talking about the sympathetic autonomic nervous system, which is at fault in terms when you are considering system is working well, or whether whether there's any other cause of orthostatic hypertension. And there are certain tests that you can do. Especially the cardiovascular autonomic function test, where you look at the drop in the heart rate or increase in the heart rate. The Valsalva maneuver, where you can see whether there's a recovery of the Valsalva or shoot up of the blood pressure back again to normal, or the change in the heart rate, which is not seen with autonomic nervous system failure. So that is one way of differentiating. If you have an autonomic nervous system failure, obviously anything you won't. There is no recovery pattern which is available. So obviously, when you are standing up, you need the body to react back. And if the autonomic nervous system is not functioning, it is not going to react back. The autonomic, again, neurogenic orthostatic hypertension can be divided into peripheral and a central mechanism. That is, if you have a preganglionic autonomic nervous system involvement or a postganglionic autonomic nervous system involvement. So if it's like a classical example of a postganglionic would be something like diabetes. In Parkinsonian syndromes, if you have multiple system atrophy, you have something called as a preganglionic orthostatic hypotension, whereas Parkinson's disease by itself has got a postganglionic orthostatic neurogenic orthostatic hypotension. So if you and there are some autoimmune disorders, especially if you have a paraneoplastic manifestation, you can have an autoimmune autonomic ganglionopathy where there are antibodies to the cholinergic ganglion, cholinergic endings of the ganglion. So these are exactly, this is the, so they act on the ganglion. So obviously the transmission is stopped. So they come in between. So you have a preganglionic, then you have a ganglionic, and then you have a postganglionic. So the point is that if you have, so how would we differentiate between preganglionic and postganglionic is that there are certain tests which you can help. You can see, like if you see the plasma norepinephrine levels, which would, if you look at the supine levels and the orthostatic levels, if there is a change and there's an increase, that usually suggests a preganglionic neurogenic orthostatic hypotension. If the levels are not changing, that means that there is a postganglionic neurogenic orthostatic hypotension. We can do an MIBG scan. The MIBG scan is normal in case of a preganglionic lesion. A postganglionic lesion, the MIBG scan is abnormal. So these are certain, they're not foolproof, but they give us a clue. But basically, most of the times we don't rely on the test. We actually, it's the setup. Clinically, we actually look at the setup and then we decide. So if you have a patient who's diabetes, who's got diabetic neuropathy and develops an orthostatic hypotension, we consider it to be a diabetic orthostatic, autonomic neuropathy. We just look at the Valsalva and we'll look at the change in the heart rate on standing. We do, there is a, you can do a tilt table test to look at the change and monitor it properly. You can do a cardiovascular autonomic function test. And then if you're sure that it is neurogenic orthostatic hypotension, you manage accordingly. So the problem with neurogenic orthostatic hypotension, either preganglionic or postganglionic, the other question that you asked me was whether it could be a manifestation of stroke. Till date, I haven't seen any patient who has, stroke presenting as an orthostatic hypotension. I have not seen any patient, but orthostatic hypotension causing stroke, yes. Orthostatic hypotension causing seizures, I've seen patients. They actually came to us as seizures. The patient had repeated recurrent seizures. He had no signs. He didn't. It was a very acute onset. And the only clue for us was that he had a seizure. Actually, the only reason why we picked it up was he had a seizure in the OPD when he got up from the seat. So then we realized that there was something wrong and there was something to do with standing up. And then we went back in the history and we found out that the seizures were all happening in the morning when he was getting up from sitting position. So as a manifestation of stroke, I'm not sure, but stroke by its, like suppose if you have a cervical demyelination, or if you have a locked-in state, along with the other manifestations, you can have orthostatic hypotension. But as a pure manifestation of a stroke, I am not so sure. I don't have any experience with that, and I haven't read about it either. As a manifestation of other disorders, yes, multiple system atrophy is one of the diseases which can come with an autonomic disturbance. And that's one of the, it's a Parkinsonian syndrome, so they will have mild Parkinsonian features, but they have a predominant orthostatic hypotension. So it becomes very difficult to treat them. As Dr. Somraju sir had already mentioned, and Dr. Raghu sir had mentioned, the drugs to treat Parkinson's disease like levodopa causes a drop in the blood pressure, and that they cause orthostatic hypotension. So you have to balance between giving them medication to improve their motility and at the same time making sure that they don't fall because of orthostatic hypotension. So the multiple system atrophy patients who they have involvement of the cerebellar system, the basal ganglionic system, and the autonomic system. So these patients have they are very, 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 very sensitive to levodopa. So even small doses, they tend to have orthostatic hypotension, and they have very severe supine hypertension. So it is actually, the whole the line is between the devil and the deep blue sea. It's very difficult to manage them. You have to really be careful. They develop a stroke secondary to the hypertension, or they have a fall and they have injury secondary to hypotension. So multiple system atrophy. So this is a feature which can happen. Autoimmune autonomic neuropathy can present as a pure orthostatic hypotension. So they can just come with autonomic disturbances. But normally they also have other involvement like micturition abnormalities, sweating abnormalities. So there are suggestions to suggest that it's a neurological disease. But they can come with orthostatic hypotension. So that these are the diseases which can happen. We prescribe fludrocortisone and midodrine quite often to patients with orthostatic hypotension, especially if it is Parkinson's syndrome. Midodrine was not available very easily till recently. So initial 10 years back and all, we were giving them all fludrocortisone. So all the patients would be put on fludrocortisone in the morning, 0.1 milligram, then they would be asked to take another dose in the afternoon, avoid the dose in the night, make sure that they are lying down with the head thrown up to avoid the supine hypertension, and we would start the whole process again. Midodrine can be given again in 5 milligrams 3 times a day. Again, the problem with midodrine and fludrocortisone is that supine hypertension really gets aggravated with them. So, and they have other issues of, if you are giving fludrocortisone, then you have water retention, weight gain, problems again associated with motility. I think I've answered most of the questions. If there's any other question, I get answered.
You indeed answered most of the questions, ma'am. Thank you so much for that time and insight. We have Dr. Guru.
Hello,
You have something to add? Yes, sir. Please go ahead.
Yeah, see, a couple of things which one is from that, like, we heard Dr. Rukmani's view, which was a neurologist standpoint, probably as a general clinician, probably you, me, and other non-neurologists. It's a simple thing actually. If the drop, you have diagnosed hypotension, postural hypotension. If the heart rate increases beyond 15 beats per minute between the supine and the standing, it probably is non-neurogenic. That is one thing which is given in most of our clinical examination methods. One point is that. Second is that supine hypertension is a big challenge with fludrocortisone. It may be less so with midodrine. I had there's a drug called droxidopa which is available in the West, which is not probably available in India. I've never used it. Pyridostigmine is something which can be used in orthostatic hypotension without the side effect of causing supine hypertension. I'm not sure if Dr. Rukmani can answer this if she has used pyridostigmine, because that is one thing which is not known to cause supine hypertension among the drugs.
So you're absolutely right, sir. The drop in the, as you said, that change in the heart rate is very useful. The other thing that you can also do for checking out is that you can look at the parasympathetic component also. So you can have somebody pressing the BP cuff and checking the rise in the diastolic blood pressure of more than 10. So again, if you have a rise in the diastolic blood pressure after persistent resistance, that also suggests that the patient doesn't have a neurogenic orthostatic hypotension. We do use pyridostigmine quite commonly. Pyridostigmine is useful in patients with a preganglionic orthostatic hypotension because the cholinergic transmission is what is there at the ganglia. So for multiple system atrophy, pyridostigmine is a good drug. But for Parkinson's disease and diabetic autonomic neuropathy, it really doesn't work so much because it's the postganglionic involvement and they don't respond to the pyridostigmine. But you're right. So pyridostigmine you can give. Actually, we give them 60 milligrams twice or thrice a day, and works in multiple system atrophy. Droxidopa, but I have no experience because it's not available. It's supposed to be used. If you have complications with midodrine, droxidopa can be tried. So it works on the same principle as midodrine. So so the supine hypertension component is supposed to be lesser with droxidopa compared to midodrine.
Thank you so
One
much.
more thing, Anup, I'll add is that neurogenic orthostatic hypertension will have triggers. For example, aggravation of the hypertension with either a meal or with exercise actually points towards a neurogenic cause than a non-neurogenic cause. So that is also a pointer towards neurogenic orthostatic hypertension. So rest actually, one more thing which I want to tell, I think I don't know whether one is that explaining to the patient when he's getting up from the supine position to hang his legs down for a few minutes. Also crossing the legs for 30 seconds actually does help in the passive venous return. That's something which we can train our patients to do when some of the drugs are which we cannot pull out. For example, if patient is on tamsulosin is having really bad prostatic symptoms, we cannot pull out the drug. But at the same time, telling him to get up in the morning with his legs dangling down and then crossing the legs to compress the venous system for 30 seconds or so does increase the passive venous return.
Perfect. Thank you so much, sir. We have Dr. Shyam Jaiswal. He's a neurologist at Care Hospital. Dr. Shyam, I have got a few particular questions for you. And since you joined late, I will also brief you about the clinical discussion that we are having. We have an elderly gentleman who has got multiple cardiac issue. He's stable right now. He's on routine antihypertensive medication, and he's having documented orthostatic hypotension. My question to you as a neurologist is, number one, whenever we have a new onset orthostatic hypotension without any major change in other clinical status, should we be asking our neurology colleagues to do their own assessment in case if we are missing something? If we routinely do it, are we going to overcall neurology? That is one. And second, if you could share your thoughts about your experience with using metodrine and pyridostigmine in this kind of patient population. Dr. Shyam, if you could unmute
Yes.
yourself. Yeah, please go ahead.
As Dr. Kumani Madam, she is being a movement disorder specialist. She mentioned all the details where we use the midodrine in the case of movement disorders issue only, mainly Parkinson's and Parkinson-like disorders. Usually where we use the midodrine. And definitely whenever any patients with a new onset orthostatic hypotension, definitely I will try to detail examinations, what are the regions. Definitely better to call the neurologist to look for, if we are missing any kind of movement disorders, or it is just really orthostatic hypertension, or it's pre-syncope or something else. So definitely it's better to have a co-consultation with the neurologist. And pyridostigmine I never used, but definitely midodrine we have used for many patients in case of MSA and other kind of Parkinson problems. Thank you. And Dr. Kumani Madam has covered already so many aspects. As Madam told, the stroke, we have never seen the orthostatic hypertension coming as a presentation with a stroke, a clinical feature with a stroke. Yeah. Thank you, Dr. Noop.
Thank you, Dr. Shyam, for your comments. If anybody has got any questions or comments, you can please unmute yourself.
Anup, I had one point to ask neurophysicians whether
yes, sir,
B12 deficiency or thiamine deficiency contributes to the autonomic dysfunction, because others people also tend to have B12 deficiency or maybe coexisting thiamine deficiency, because if it has demyelination has effect on the peripheral nerves, does it have an effect on the autonomic nervous system also, and these deficiencies can cause a aggravation of the symptoms.
Dr. Shyam, if you could.
I totally agree, Dr. Guru.
Yeah.
If patients having we have not find any cause for the hypertension, definitely vitamin B12 we check for, because vitamin B12 affects sometimes the autonomic nervous system, even thiamine also, and can cause such hypertension. Definitely, totally agree with you.
So, Dr. Shyam, my follow-up question to that will be: when you replace these deficiencies, do they actually get better? Like, what is your experience on that?
Seen with many patients when we load with the B12, they definitely improve. If we find that they have the significant B12 deficiency, they improve also. Yeah.
Perfect. Thank you so much, Dr. Shyam. And I'm inviting anybody else has got any other suggestion. I have few particular questions which I have gathered from the chat box, and I'm going to ask my audience. Dr. Prashant, if you could unmute yourself. Dr. Prashant is our cardiologist at Care High Tech branch. Dr. Prashant, I have got a particular question about this case. Patient comes to you with orthostatic hypotension with prior cardiac issues, now stable otherwise. Do you look for carotids in these cases? Role of carotid ultrasound, and do you recommend leg stockings in these cases? What is your experience of whether they actually work or they don't work? Dr. Prashant, if you could unmute yourself.
Yeah, I mean, as part of the evaluation process, I do check their carotids, and if they are like long-term diabetic and with uncontrolled diabetes with some amount of neuropathy, so autonomic neuropathy has to be thought. And in a few of such cases, I do advise stockings, but not sure how much they help. But maybe mild symptoms they might help. What I find in my experience. So that's point to debate, like stockings, how much they are useful in severe cases.
And Dr. Prashant, have you ever advised somebody abdominal binder? This is something we used to do it in US quite often, but I have
No,
never prescribed anybody here.
no. I've never advised anyone. I've seen like one or two patients using it, but from my experience, I've never advised like anyone abdomen binders.
If anyone in the audience, if they have any experience about prescribing or using in your patients abdominal binders, do they work? How do you prescribe? Is there a brand or a pressure limit or something? If anybody has any thoughts on that, please feel free to unmute yourself and share your thoughts. Dr. Somaraju, if I could have you share your thought one more time, because I'm going to ask you specific questions. This midodrine business, we really don't have very good idea about when to use in cardiac patients, or would you say we should never use it in cardiac patients because there is always some medication adjustment that we can do? Do you use midodrine, and have you ever used abdominal binder as well?
Thank you, Anup. We do come across a significant number of patients with postural hypertension, and with adjustment of existing medications and alterations in medications, we never had a reason to use any of these drugs. I am worried about use of these drugs because we don't have enough experience, and most of our patients have significant other problems where these drugs are not tolerated.
Thank you so much, sir. And sir, if you could share your thoughts about abdominal binders. Do you use that? Does it work?
See, abdominal binders are often tried in the West, but the experience everywhere is they are extremely uncomfortable to wear, and it's almost like you got pregnant. There is a feeling of pregnancy in a male person, so it's impossible to wear, and unless there is no other choice, we should avoid it.
Perfect. Thank you so much, sir. There is one audience question about treatment plan for diabetic orthostatic hypotension. I don't know if Dr. Vrinda is still with us. I can see her in the audience. Dr. Vrinda, if you could just unmute yourself. For non-cardiac patient, diabetic orthostatic hypotension, how do you manage these patients? What kind of behavioral or pharmacologic therapy that you offer? Dr. Vrinda, if you could unmute yourself. Dr. Vrinda, are you still there with us in the audience? Probably she's not able to hear me. Anybody can? Yeah. Hi, Dr. Vrinda. Please go ahead.
So for diabetic autonomic neuropathy patients, I think, of course, behavioral modification, like Dr. Guru Prasad mentioned a point about crossing the legs. We do tell them to, of course, the postural changes should be slow, and, sometimes we tell them to cross their legs. But the experience that I have for these patients is using midodrine mostly. So my experience is just limited to that. But yes, we do we do tell them to make these lifestyle changes, these postural changes, especially when they're changing their posture, and midodrine as and when needed.
Perfect. Thank you so much. And I just want to highlight in 2-3 minutes about the reason why this topic was chosen for discussion, because as a cardiologist and as a internist, most of the time, we don't see the primary neurologic issues causing this. We see our routine random Joe who is in their 70s and 80s who come in with these symptoms. And as a good doctor, if you don't know a lot, you go online and you start reading. Well, when you start reading, there are few issues that come across for orthostatic hypotension, and none of them helps us. Because from a cardiology standpoint, there are a lot of things which are pretty standard that we do to our patients. And it is those standards which are conflicting with how typically academics tell us to treat orthostatic hypotension. Like if you go on any data set, they would tell you beta blockers are one of the major culprits. Well, the problem is almost all of my patients are on beta blocker who have heart problems. So now the question is, How do you challenge that? One of the behavioral therapy that is instituted is fluid challenge. And the idea here is before the patient wakes up, particularly early in the morning, you tell them to load them with a lot of oral fluid, which is typically water, that kind of triggers a sympathetic reflux because you reduce the tonicity of your blood or serum, and that triggers a sympathetic reaction which combats that orthostatic hypotension. Well, the problem is I'm asking my patients to reduce their fluid intake, so that fluid challenge doesn't work. One of the drugs which is implicated commonly is diuretic or vasodilators. Well, most of the patients are on those drugs. Abdominal binders are very inconvenient, as what Dr. Somaraju suggested. And even the leg stockings, when you look at the data set, most of the leg stockings which are below knee, they are useless for orthostatic hypotension prevention. In fact, you have to go up to the waist length. And in cardiology, you would pretty much concur with me in lower extremity edema, asking patients to wear a knee length stocking is such a big issue in terms of compliance, let alone a waist length stockings. So a lot of these things that we discuss about treatment, if you go into any literature, there will be a table which will be filling the entire page of what all we can do to treat those patients. But in a typical cardiac patient, a lot of these therapies either conflict directly with what we are doing, or they are they are not compatible with the patient's lifestyle. And that is where the management challenge comes with treating these patients. And it's almost like buffet where you have to sit and discuss with the patient to see which of these you can employ in these patients, other than everything else we discussed, which is making sure they are on the right medication, making sure we're not giving them too much, particularly diuretic therapy and whatnot, and a certain level of acceptance that these patients will have supine hypertension. How much can we accept, how much aggressive we have to be, that is also an open discussion. So that is my rationale of why we wanted to discuss this particular topic, because of these management challenges. I certainly think we underutilize neurology opinion in these kind of patients, because sometimes we may be overlooking certain things. So just having an opinion from an expert doesn't really cost too much. So having said that, we are close to 8:30. If anybody has got any other thoughts about orthostatic hypotension, any tips or tricks that you do in your patients that works, please share with us. Unmute yourself and let us know what you do in your patient subset. Anyone who has got any suggestion? Guru?
I think Anup, one thing which we need to keep in mind is use of antidepressants, which are very common in your cardiac patients. Be it SSRIs are very common, because TCAs normally cardiologists don't use because of their inherent, arrhythmogenic potential. But most of cardiac patients I've seen are on maybe citalopram or sertraline, but they are also one of the main culprits of causing orthostatic hypotension. SSRIs are also one of the main culprits. So I think if you can take off those unnecessary drugs, then you not meddle with your main, your frontline cardiac drugs. So that's one thing, one point I would like to make.
Guru sir, thank you for bringing that up. In fact, I did wanted to mention this Nexito plus business in cardiology, particularly elderly, that has to stop, particularly when you have any signs and suggestions that these patients may be at high risk of fall. Not particularly because of benzodiazepine in that Nexito plus, but the TCS or the amitriptyline or nortriptyline, those kind of drugs, they certainly are implicated. The other thing I also want to warn my attendees here, that many of the, and it is pure marketing, nothing else, many of the companies who make your standard cardiovascular drugs, they unfortunately are in the market making mitodrin as well. And there is a lot of push towards prescribing because we are their market base. And just like we are their, their target for cardiovascular drugs, unfortunately, we also become the target to work on these other drugs, particularly mitodrin. And as Dr. Somaraju suggested, that most of the patients in cardiovascular space will not need drugs like mitodrin, which can produce significant supine hypertension. And these guys can get into real trouble, particularly at nighttime. They can get in real trouble. The other thing what I also want to highlight is please look into nighttime diuresis of these patients. Many of these patients, they have frequent urination at night. That is one of the reasons why they have early morning symptoms, because by the morning, they are technically fasting for about 7-8 hours. So if they go to urinate for 2-3 times, they may be relatively dehydrated, and that certainly precipitates that symptom. So understanding what the nighttime diuresis symptoms are and try to see if we can prevent those a little bit. Also, all the cardiac medications, if we can tune it around in such a way that we give most of the drugs in the evening rather than morning, so that they don't have those orthostatic symptoms, but warning them that if they wake up at night, they have to be very careful. So these are some of the tricks I play around, and I'm sure all of you have got your own tricks. If anything it comes to your mind offline, please share with us, because this is a difficult subset for us to manage, particularly in the cardiovascular space. If anybody has any other thoughts, they can share. I will ask Praneeth to give me his remarks on this particular case. Before I do that, Dr. Rukmini, you are attending the Huddle for the first time. It's a different kind of format where we discuss about routine, not glamorous, basic clinical scenarios. What is your feedback, constructive criticism I would ask for this kind of format, not the topic, but the format? Dr. Rukmini.
Thank you actually for inviting me. This is a really nice format, and I think it's a good format, and I think I'm colleagues and start a format like that in neurology too. It's a very nice format because this is something like it's a question of how to do it rather than having a didactic lecture or I mean, it's like everybody's experience is put together and really come up with answers. So it's very nice, and I'm really glad that you invited me, and it is an honor to be here. Just the last, statement on the just one point is that this is something which is very underutilized. The position of the bed, that is a head up tilt or whatever, the tilt of the bed. It's not the head up basically. It's the whole bed has to be tilted up to around 10 to 20 degrees, and this is something which we see does work quite a bit because it prevents a nocturnal neuriosis, it prevents a nocturnal hypertension, and it definitely reduces the orthostatic hypertension. So we just tell them that you take the 2 bricks or 4 bricks and put it under the legs of the bed on the head side. So that's a good option for orthostatic hypertension, which is actually very underutilized, and it can be done very simply. But I mean, that is beyond the point. But this is really nice forum, and thanks again for calling me.
No, I think putting that bricks beneath the legs of the bed, I think that's a very fantastic cheat that people can use. I hope they don't fall down when during the night, they don't slide. So, but certainly a very good thing that we can institute. Praneeth, your closing remarks for the session, and then we'll be done after that.
Yeah, it's indeed a very interesting session. Thank you everyone for putting those inputs. Thank you, Dr. Rukmini and Dr. Shyam, for your inputs. Yeah, so many tricks. The bricks is a fantastic idea. Crossing the legs is a fantastic idea, and many points to take home and to put it in practice. So thank you everyone for sharing your thoughts and amazing discussion.
Thank you all for attending today's session. Special thanks to my guests, Dr. Rukmini, Dr. Shyam, Dr. Guru, who had been joining recently for today's session. To the attendees, particularly those joining us for the first time, we would like to get your feedback, particularly constructive criticism for the session. If there is anything that you think we can make better, please share your thought. If you found the session worthwhile, maybe request you to share it amongst your colleagues, because the more people join and the more people share their thoughts, better it will be. The weekly huddle is hosted every Wednesday, like today, 7:30. And the link that you clicked to join, that is the same link for the future session as well. So even in the future, if you don't get an invite, first of all, that will be my mistake. But in case if you don't, you can simply just click the old link and you should be able to join future sessions. All the huddle sessions are recorded and the recordings are available on podcast and YouTube. You can simply just search for them, or you can email me and I'll share you the recording. I thank you again for your time, for participating. Good night, and I will see you all next week. Thank you all.
Thank you, Dr. Anup.
Thank you.